Hello. We're about to start. I think the conference is a little delayed. As you can see, I am not Isabella Golding. I would need genetic change and maybe some bleach and less cake to be Isabella Golding. She sent her apologies. She's been delayed in Nottingham. She had a meeting in Nottingham, and her train times delayed, and so she wasn't able to join us. So my apologies for that. I'm Christine Gula-Burke, and I work for the Mental Health Foundation, and I head their inequalities work. And I included in that is the Foundation for People with Learning Disabilities. And I've been asked that, as you can see at the last minute, to come and introduce this really important panel, which are going to shed some light on some of the issues around prevention. And I'm really looking forward myself to listening to them as a delegate, let alone as chair. There are times throughout our lives when we all feel the pressure of everyday living, and it's so across the whole life course, from children moving from school to school, secondary to primary to secondary, moving home, to go to university, losing a loved one, or being married or divorced. There's all sorts of things, and as we heard in the previous session, pressures of being at work and stresses. And as we hear in the news this week, firemen having extreme stress in their lives and having to be looked at. So prevention is something that we need to bear in mind and think about if we are to make any changes in the way that we contribute to public mental health. If we need to rise to the challenge to reduce the prevalence of mental health, and it's rising, and we can see that it needs, in the first place, a societal change. If we are to truly recognize good mental health as a universal asset, because with good mental health we need to strengthen and protect good mental health, which is why we need to start from young, a totally intergenerational issue. So despite the challenges presented, it's important that we look to a world of hope, and I'm really pleased that this conference is entitled Hope. If we are to such a world to realize our potential and control our lives, because controlling our lives is so important, particularly when thinking of the foundation side of the work I do with people with learning disabilities. Lack of control is a high stress in terms of poor mental health. And our focus on prevention needs to really focus on prevention, not just numbers and statistics in terms of poor health, but maybe starting to think a stage before that, starting to think, how are we going to prevent poor mental health? How are we going to make sure that people are happy at work? How are we going to make sure that children have someone to talk to, someone that they can say without shame that they're not feeling well? We are heading towards a mental health crisis, and we need to, the evidence from our survey at the Mental Health Foundation suggests that 1 in 10 kids are self-harming. 2 in 5 people have experienced distress. 1 in 5 have suicidal thoughts. 65% in our survey say they had mental health problems, and only 13% good mental health. We can't afford to keep this going and meeting failure. We need to start thinking, how do we start the prevention agenda? For example, we need to start investing in prevention and early intervention, not just talking, not just the rhetoric, but starting to think how we can make it real. Shift attention to public mental health, expand mental health services in our schools, making sure that children are supported to live long lives and to thrive in school. Through the strength of local communities, we can collaborate to create effective and cultural competent solutions. And they are crucial if we are to make a change, which is why this panel today is so important. And I start by introducing Professor Ilona Finlay, Baroness Finlay of Llanllech, from the House of Lords. And Professor Finlay is Professor of Palliative Medicine and an independent crossbench member at the House of Lords. She's past president of the Royal Society of Medicine, and she's professor of palliative medicine at Cardiff University School of Medicine. And I think her resume in the folder is extensive, and the bits that I'm looking at particularly for today is the work that Professor Finlay did in terms of the bill to ban smoking in public buildings in Wales, and some of the works in terms of opting in and opting out of donor change. So I think without further ado, I'll pass you on to Professor Finlay.
Thank you. Thank you very much. Well, I'm speaking to you today with my hat as chair of the National Mental Capacity Forum. You will be aware that the Mental Capacity Act went through in 2005, implemented in 2007, just almost exactly 10 years ago to the day. And the Post-Legislative Scrutiny Committee was quite critical of it in terms of how it had been implemented. So I've been employed by Ministry of Justice and Ministry of Health, Department of Health, for one day a month to improve the implementation of the Act. I have no budget, no staff and no office, so you can see that it's obviously a very well-resourced task. So I'm relying on all of you to help. So basically, laws send social messages. Banning smoking in public places was a powerful social message. The tobacco companies hate me. But the Mental Capacity Act, the social message was about empowering people to take the decisions that they can take and get rid of those kind of blanket stigmatising judgments about people's capacity. So I've been working with all sorts of groups, particularly those with learning difficulties, impaired capacity, the finance sector, banks, building societies, utilities, equity release and so on, carers, court of protection, Office of the Public Guardian and everyone, as well as a bit of health and social care logged in there just to make me feel comfortable and keep me in my comfort zone. And I have taken some of the illustrations for this talk from the Council for Disabled Children document. They have a fact sheet on the Mental Capacity Act and supported decision making, and I would really commend it to you if you want to read one thing in 15 minutes and just have one resource there on supported decision making. I think it's really a very good one. How many of you can, oh, the lights have gone, okay, I can still see you. How many of you, raise your hand, could tell me the 5 principles of the Mental Capacity Act? Put your hand up in the air if you can. Surely somebody can. No, nobody can. Okay, fine. That's great. Gives me an opportunity. You're all going to learn it in 2 minutes flat. Nobody gets out of this and I can see you. Okay? Everybody, raise your left hand. Okay? Your pinky. You presume somebody has capacity for that decision at that time unless you can demonstrate that they don't. The bigger the decision, the more capacity they have to have. Okay, that does not include life-ending decisions, though. They're excluded from the Act. The next one, your ring finger. Some people need support to make their own decisions. That's what I'm going to talk about with you. But you can all make unwise decisions. Everybody can and does. Those of you with a wedding ring on may think that was an unwise decision. Talk about it over tea. I don't want to hear about it. But I'm going to a pincer movement. If you have to take a decision on behalf of somebody else, it is a best interest decision, which means it is about them. It is not about you. It is about what they need and what their options are, not what suits you, not what suits the NHS, not what suits the budget or the local authority. And you should go for the less restrictive option. You do not keep them under your thumb. The least restrictive option that you can. Okay, I'm going to focus now on the ring finger, despite some of you having a wedding ring on it, which is around supported decision making. And what's the role of supporting decision making? Well, it is to help people plan with their families, with their friends, knowing what's important to them, and using those people around who know about a person to literally support them making their decisions, so that even if they can partly make decisions and some of that decision making is in the best interest category, then you are still using as much as you can of the person's own ability to take a decision. Now, there are two other bits of legislation that interact with this. The Children and Family Act, which says that it's full of shoulds, actually, who should support the communicating need and aspirations of children and young people. Local authorities should have staff who are trained, and they should ensure there is support available for decision making, and that children and young people feel valued. But they do have a must in there, which I think is important. As well as children and young people being entitled to the same quality and level of information, advice and support as their parents, there is a must, and that they must have confidence that they're receiving confidential and impartial information, advice and support. So it actually puts the young child or young person with learning difficulties, but that may be somebody older who's had a head injury or who's had neurosurgery or who's mentally ill or whatever, but it does put them on an equal footing with those who have capacity in the decision-making arena. And then the Care Act brings in advocacy and so on. But interestingly, P, the person at the centre, must agree that the person proposed is the right person to support them and must feel comfortable with it. It isn't just that you can pull somebody and lob them on and say, right, this is the person who's to support you. And if an independent advocate is appointed, that does not exclude family and friends. They should still be included as much as possible, get as much information about the person as possible, and the local authority has a duty to provide support. And in the Mental Health Act, you can't take decisions on behalf of someone else in intimate and personal relationships, which is around consent to marriage, consenting to sexual relationships. And interestingly, voting in elections, gosh, doesn't that reflect Parliament? Imagine thinking that that is an intimate relationship. I think some people would wish it was all torn up. But there we are. And the action, but it doesn't mean that you can't take action to protect the person who's vulnerable from abuse or exploitation. Now, fine, all that's laid out in legislation, but what do you do in practice? Well, I think the most important thing you do is you listen. I know some of you can read Chinese symbols, but for the rest of you, this means listen, okay? And I think it's the best example because you listen only partly with your ears, but you listen with who you are, with your eyes, but most importantly, with your undivided attention and with your heart. You listen from the heart. And the person who is being listened to knows straight away if you're not listening from the heart and if you're not listening with your undivided attention. And you will not get the information that you need to help and support them make a decision unless you listen with those. You don't need your ears as much as you need your eyes and your heart. They're really important. And a good supporter is, people have said, someone who understands my needs, can talk or communicate with me in my way, gives me clear information, is trustworthy, is interested in me and my ambitions, listens to me, and has an understanding of my needs. Now, in terms of the 4 steps to assess decision-making capacity and decide how much, and looking at where you put the support in, I've said it is that decision at that time. So first of all, is there a disorder of the mind or brain? But importantly, does it interfere with the decision-making? So you, as the person supporting, have to filter out which bits can they take decisions over and which bits of that decision-making process can't they? And can they understand and retain the information? Some bits of information they don't need to retain for very long. Other bits it's very important to be able to retain them for longer in order to plan what lies ahead. But the step that's usually forgotten about is the weighing up of information, and that's where people may need support, because they may well need help to think about the implications for self and others, and they may need that presented in very clear, simple forms. It may be with drawing, it may be using little figures or toys, it may be with gesticulating. You know, it's usually not a pamphlet. In fact, it's almost never a pamphlet. I just wish we'd get rid of information pamphlets across health and social care, because I do think they're a waste of paper most of the time, apart from instructions before you go and have a procedure done. But I'm digressing. It help people weigh up. You know, that's all about personal contact, isn't it? And then, of course, communicating their decision. And if they don't have language or can't speak, then you'll be assessing communication in different ways. And if you have to ask a question and look for a response, remember to ask it the other way around as well, to make sure they're not just saying yes to everything. I've seen so many times people with lack of speech being so-called assessed, and they're just being given loaded leading questions. And then people say, oh yeah, they said yes to that, and they said yes to that, and they said no to that. Well, it's the way the question was presented. You've got to present them back to front as well to see if they're valid. So, for young people preparing for adulthood has got lots of domains around employment, independent living, inclusion, and of course health, and in particular their mental health as well. So if they're going to be actively involved and enabled to participate, there has to be a focus on positive life outcomes. It has to be person-centred and independent as possible, with confidential and impartial information. And that can be really difficult when you've got that elephant in the room of the pound sign and a limited budget. And you have to be honest about what the budget will and won't do. And I think one of the problems is people aren't honest about budgetary restrictions and things that can't be done. And of course then expectations get raised only to be disappointed later. And of course, I said information had to be in an accessible form and readable, and different ways of doing it. And it is only by doing that and putting it all together that you can come up with a plan and help people with decisions and find the right decisions for them. If you want to know more about it all, go to the Social Care Institute of Excellence website. That's me doing the 5 fingers. If you want a revision course, that's why I stuck that one in, just in case you've forgotten. When you send me the names of 100 people that you've taught, I'll give you a House of Lords bar of chocolate. It's expensive and it's quite good chocolate, but I do want people to at least understand what the Mental Capacity Act's about. Thank you.
Thank you. That was amazing. Thank you. And I'm always pleased when someone brings in the other elephant in the room, which is people with learning disabilities. And as one of the things I had, I always look out to see if someone remembers those most vulnerable. So thank you. You've made my day. I'd like to introduce you to Sarah Pickup, OB. And Sarah is the Deputy Chief Executive for the Local Government Association, and I'll let her tell you more about herself. Thank you.
Thank you. I don't think you want to know any more about me, do you? You want to know a bit about what I've come to talk about. I'm not a mental health professional, I'm not a social worker, but I've done a lot of work in social care. I was Director of Adult Social Services for 10 years. And I think that one of the things we need to do is make sure that everybody's thinking about it. And it's not only psychiatric nurses and mental health professionals who are thinking about mental health. And I think there is a real and much broader role for, which has been touched on already, for society and for councils as part of their local communities to make sure that mental health is part of the kind of community infrastructure, it's something we think about. We talk about this for a lot of things, about how important your kind of wider determinants of health are, but the wider determinants of mental health are important too. And so some of what I'm going to talk about today is in a publication which is in your bags, and it's called Being Mindful of Mental Health, the Role of Local Government in Mental Health and Wellbeing. And so I'm not just going to talk about mental health, by which we normally mean we're going to talk about mental illness. I'm going to talk about mental well-being and some of the things that have already been touched on in terms of education and so on. So with community mental health, it is very easy to focus on illness and rather than how we keep communities mentally well. And being mentally well involves all sorts of things, and people have crises and they have life episodes in their life where they might be bereaved, or they might get married, or they might get divorced, or they might have a child, and all sorts of things in your life can trigger an episode of mental illness. We've had really quoted already lots of the statistics about the prevalence, and I noticed myself in the papers this morning the report about young girls, teenage girls, 1 in 4 experiencing some form of anxiety or depression. And any of you in the room who are managing people at work will know that this is something that happens to people. It may have happened to you, and we need to think about how we can help people never get to the level which involves an admission to hospital or the need for a mental health social worker and so on. You can't prevent everything, but there are some things that by working in different ways we can prevent. So this is about how we help people live their lives. It's about the design of towns and cities. I know there's some architects here today. It's about access to green space. It's particularly, I think, about having a job and a place to live. And housing and employment are just so critical and fundamental to underpin people's kind of self-esteem and mental well-being that we just shouldn't underestimate them. And I think at the heart of many of the most complex problems that we have in our communities or individuals have in their lives is a mental health challenge that might be caused by or might cause, and cause and effect is difficult to determine, some much broader challenges which can range from people being anxious and nobody would ever know about it, through to people with very complex needs and who are unemployed, perhaps lose their home, have drug problems and all sorts of things that go with it, and perhaps lose their families as well. So I think having a pleasant place to live, yes, pleasant, or a place to live is a start, isn't it? Pleasant place to live is even better, that can support you better, just helps, it's part of being healthy. So councils have a role in that because councils are, in a sense, leaders and guardians of place. I mean, they are just enablers, they are deliverers of particular statutory and non-statutory services, but they are also should be looking to help lead their communities, to help other people in the communities have a voice, and to make sure that communities are enabled to support themselves as well. Because a lot of the things that support people the most are things that they enjoy doing or want to have access to, which will be everyday facilities in their communities, the opportunity to socialise with people, the opportunity to take part in activities which they enjoy, whether it's music, whether it's sport, or whether it's a book group. But you need sometimes, some people at different points in our lives, we all need a little bit of help with some things, and making sure the little bit of help is available when it's needed, as well as encouraging people to help each other, which is what a lot of us do all the time, is really important. So the statutory roles obviously cross into social care, public health, and then the things around housing and education. And I think, if you think about that statistic about young girls this morning, the education bit is critical, and how to thrive type of courses. I know when I worked in Hertfordshire, they were running some of these programs through the secondary schools, and it was, it's very successful in raising awareness and enabling kids to raise issues and to help tackle them sort of before they become overwhelming and start to affect their education and their health. But the non-statutory bit in terms of the role of councils is about the kind of environment that people live in, and it is about having a nice environment, parks and green spaces, access to culture and leisure. They seem like nice to haves, but they're part of a good life, aren't they? It depends what you like. We don't all use all of them all of the time, but there's something for everyone in a community, and people should feel comfortable in the places that they live. So I've been party to some of the mental health task force work that was done last year. And I've sat on the NHSE Strategic Mental Health Programme Board, and we've talked a lot about what's needed for people with mental health. It's great that there's more investment, although sometimes you do wonder whether it's just recycled from somewhere else, or it gets recycled to somewhere else once it's allocated, and it is a problem with mental health services, I think. But often when I sit in those meetings, there is a tendency to forget this broader set of things that people need to be mentally well, and not just to be mentally well, but to recover after they've been mentally ill. And so, it tends to, we look at there's a liking for pathways in the medical world that was talked about in the supported housing session earlier. There's a liking for pathways, but actually the pathway doesn't end when you leave hospital or you leave the care of clinician. The pathway to recovery stretches further. So I was really pleased to attend the session on supported living and to hear about people's ambition around holistic treatment in communities and step-down care. And, you know, it's not just about buildings and supported living, it's also about direct payments and personal budgets, and gradually moving people through a path, an extended pathway that leads them to independent living with only intermittent involvement with services, which may be, you know, contact with the voluntary sector or contact with peers or people that have been through the same experience. So there's all sorts of things that are needed, and I think the prevention and early intervention end is critical. It does link to, with children, it links to the work in schools, and with kind of very low-tier services before people get into more crisis. And too often, as with actually a lot of healthcare, you need to be beyond a certain level before you get the help. And, you know, it's the wrong way, isn't it? You need to tackle the causes, not the symptoms. And we need to invest more there. With older people, we know that loneliness, you know, is as dangerous as obesity and smoking, social isolation, and mental health, you know, is certainly not assisted, and it's often detrimental to mental health. You become depressed and isolated and withdrawn. We talked about children, and the statistics today illustrate with girls. I mean, it's not just girls. I know that in young men, there's some particular challenges around mental health as well, and from different minority groups, which of course you'll be working on in your role. Public Health England have a prevention concordat for better mental health services, and it's really important that we pay more attention to that end of the spectrum, I think. So we need to help build resilience, enabling people to manage everyday life. Everyday life can be very stressful, whether it's at work, whether it's at home, all the challenges we all come across. Some of us have the resilience to get through all the time. Some of us have the resilience to get through most of the time. And then for some people, there's more of a challenge. There's very few of us that don't need some sort of help to support our resilience at some point in our lives. So there are key roles for all of us. There are key roles for friends and neighbours and relatives. But there are key roles for employers and, you know, working in the public services, working in a council. If I've come across people that need this sort of support or talk to others who don't quite know what to do, and I haven't got magic answers, I'm not an expert, but what I do know is that if we in public services can't support our employees when they are in times of need, whether it's due to illness, mental illness, or actually other things like being a carer or being bereaved, then I don't know who else we can expect to do it. So I think we should be leading by example in that respect. But there is a role, obviously, for people working in public services, whether health visitors, care workers and others, you know, librarians, people working in leisure centres, not to, you know, be a mental health professional, but to chat to people, to be interested in them, to ask them, you know, to help them with what they want to do and not sort of be withdrawn and, you know, just simply transacting with the public. So we want to ensure the environment and circumstances gives people the best chance, as opposed to change, to be mentally well, as it says up there. And we do need to make sure that policies interlock and, you know, supported housing, providing a step-down home and support for out-of-hospital, you know, future funding for that is uncertain. Actually, we think about lots of what's going on in the housing world. Social housing itself is very uncertain. I think there's a greater acceptance of the need for more social housing and social housing for rent, and specialist housing sits within that, and step down will be part of that. We must make sure, though, that step-down housing is not the end solution, because actually what you want is people to move through step-down solutions into independent living, not necessarily without support, but with such support as they need. Personalisation of care, holistic support. Interestingly, in the session that was being run on supported living, there was very much a discussion about not just addressing the mental health needs of the person, but their physical needs and their other needs, their practical needs as well. And the way you become able to live independently when you have or are living with a mental health condition or have recovered from a mental illness means that you have to be able to practically manage the bills and the repairs and you know, your social interaction and talking to your neighbours, not just that you are recovered from an illness. So it's about enhancing people's ability to live their lives, and sometimes a personal budget or a direct payment or some ongoing support from either statutory services or the voluntary sector, or actually from friends and neighbours or communities can be really helpful. And planning and housing power is important in this too. And, you know, it is interesting that we have people from planning and housing and architectural backgrounds here today, recognising the importance of, you know, design of communities and housing and things within them to people's wellness. I think I've probably covered some of these points about children and families. There seems to be an ongoing challenge in child and adolescent mental health services. It's partly a resourcing challenge, but it's also a challenge of connecting the bits of the system, the role of education in schools, and what can you expect in a world of tight resources. You know, teachers needing to be trained, but, you know, teachers being under pressure as well to deliver their day jobs and the ever-changing curriculum and all the things that are expected of them. But actually, if everybody plays their part, and it's not everybody's job, you know, it's not your job to solve the problem if you're a teacher, but it's perhaps your job to flag that there might be a problem, that you can then have access to support. And, you know, schools and education, well, I don't know education authorities anymore, but schools and perhaps academy chains these days would be an alternative that have access to things like counselling services for kids that they can bring in when they see a need, and they haven't got the resources in the school to cope. I know a lot of those things are under pressure. I know some places hang on to them tight because they actually think in the long run that is a resource well spent. And then just embedding mental health and well-being. We talk a lot about, you know, embedding things and not just talking about the NHS, but talking about health in society and all the wider determinants. And we also talk a lot about parity of esteem for mental health and physical health, and this is all part of the same picture. It goes from prevention through treatment and care and support to recovery, whether it's physical or mental. And we're all people living in society. We all experience all these different challenges, and councils and you and we and communities all have a role, and we shouldn't just leave it to the professionals, important though they are, don't get me wrong, but I do think the wider picture is more often forgotten and shouldn't be. So thank you.
Thank you. I won't take too much of your time. I'll just introduce you straight away to Dr. Alain Grégoire, and he's chair of the Maternal Mental Health Alliance. So I won't take much of your time.
Thank you very much indeed. Yes, perinatal mental health. So what is that? Theresa May would say, well, perinatal mental health is perinatal mental health. But actually it's antenatal and postnatal mental health. So pregnancy in the first year postpartum is the way we use the term. And you're probably bored of seeing Theresa May, so I thought I'd take you on a little trip into the past. You probably remember this man. This is what he had to say to you. No, not the fingers, okay? I didn't want you to look at the fingers. It's what he says there that I wanted to highlight. This is David Cameron in the coalition government making an announcement of dedicated ring-fenced funding for a particular area of mental health care. And this, I have looked and searched for another example of a Prime Minister making an announcement of a dedicated area of ring-fenced funding in healthcare and haven't been able to find it. This is an extremely rare thing to happen. Not only that, but the money came through to NHS England from the government. And it wasn't money that had been spent 3 times over, doubled back and come back again. It was new money in a time of austerity. So fairly extraordinary. And you might well ask, well, why was this? Because, of course, mental health is the Cinderella of all healthcare. And actually, although we like to think of ourselves as a civilized nation, children and parents are the Cinderella of our services. In local government, in national government. Of course, we spend lots of time and attention on so-called child protection, but child protection hits about 50,000 children, and we know from the NSPCC that about 1 in 5 of you have been traumatized or abused in your childhood. So we are nowhere near touching, through child protection, this hallowed system, the actual need out there. And actually all of us who have anything to do with it know that very well. We're just doing the best we can. Interestingly, in Scandinavian countries, they spend about twice as much on supporting children and families. They also spend about half as much on their juvenile criminal justice system. I wonder if there's a link there. I'd like to suggest to you that there is, and I'd like to give you some evidence on intergenerational mental health that might give you some clues towards this. So, why? Why was the Prime Minister at this critical time in the government of the nation, and actually, well, what he subsequently went on to do at this critical time made time even more critical, but lost his job over that one. Anyway, we won't go there. Why did this seem so important? Well, because we were ready in perinatal mental health for change to happen, and there simply were no more excuses for society to do nothing, or for the NHS to do nothing, which I'm afraid is the story of mental health care over the centuries, over the last decades, over the last few years. Loads of wonderful rhetoric, rooms like this filled with well-intentioned people, never the right people, because of course I'm now preaching to the converted yet again. But no action. Or if there was money, straight off to the A&E departments, who were welcoming people with open arms, admitting them to acute hospitals, and of course admitting loads of elderly people who did not want to be in hospital or need to be in hospital because there was not adequate care in the community. So I would say shut down the acute hospitals and fund mental health services. And then we'll get to where mental health was about in the early 1990s, late 1980s. Anyway, I ramble. So this is my list of why we had these persuasive arguments, and I'd like to just summarize them in a way. And I'd start with the last one, active and consistent support from all stakeholders. In 2011, I realized that after 25 years as a consultant in perinatal psychiatry, I had done my best to deliver care to individuals, but I'd got absolutely nowhere in trying to persuade the rest of the country, the NHS, the government, services, to try and deliver better quality care, despite stacks of policy, despite loads of evidence, despite nice guidance, indeed the only nice guidance that specifies services. You will know that nice guidance specifies treatments and interventions. There is one example of nice guidance that says the NHS must provide these services, and that is in perinatal mental health. Despite that, no action. So I thought, well, if I can't do it on my own, then what we need to do is get people together. Is there anybody out there who's interested? And I only had to raise this in some hallowed corridors here and there, only to find that where we now are, over 85 national patient and professional organisations joined an alliance to speak with one voice on what needed to happen. And this has been unbelievably powerful. And I would recommend to you, if you have something that you think needs doing, make sure everybody's on board before you start making a big noise about it. But this was pretty much unstoppable. And of course, the loudest voice there is the voice of people who've lived through these experiences. Both women themselves, but also men, partners, fathers, and of course, the offspring. And I'll tell you a little bit about the scientific data on the offspring, but we should never forget them. And we are, of course, amongst those. So what are we talking about? Who are we talking about? What is this all for? Well, this is a pyramid that you see everywhere in mental health and mental illness. And of course, at the very bottom of the pyramid, we are talking about mental health. At the very top of the pyramid, we really are talking about the concept of illness. And then we have whatever euphemisms you like in between. I think in a way this is a helpful way to talk about it, and of course it reminds us that evolution has been very kind to us. The most risky and dangerous conditions that need the most expensive care from services are the rarest ones. And the most common ones that may not cause any less suffering to the individual, so that's not what severity means. It doesn't mean less suffering. There may be just as much suffering, but they're less high risk, and they don't necessarily need expensive multidisciplinary care, but they are much more common. But throughout all of those, the science is telling us, and this is the unusual triangle in perinatal mental health care, on the left, that upside down white triangle on the left, all of these levels of so-called severity, all of these types of conditions are associated with an impact, not in every individual, but epidemiologically, all of them are associated with an impact on the mother-infant relationship. And that has a long-lasting, lifelong, even predicts risk of dementia, lifelong effect on mental and physical health. How long you live is predicted by this. So really important, and that we now know is open to interventions which have an impact. So this is critically important, but also important is the other bit on the right, is that you need specialised services with specialist knowledge. And we wouldn't argue against that case in relation to physical healthcare in maternity, even though the conditions are much the same, diabetes, blood pressure, and so on. We know that we need specialist nurses called midwives, specialist doctors called obstetricians, and maternity hospitals. We are too modest in mental health to admit that there is any speciality. Anybody can do anything. In fact, you can make it up as you go along, which is pretty much what goes on in a lot of mental health care because we simply aren't investing in the skilled people we need to deliver that care. Maybe it's just too overwhelming. Maybe there are just too many people, so let's not bother. But is this the NHS based on need that we think we are delivering? No, it isn't. So what about parity? Well, here you are. Here I list all the major health complications of having a baby. And you can see the most common major health complication of having a baby by far is just one of the mental health conditions that we call depressive illness. By far. And this is a gross underestimate because that red bar of depression is actually the point prevalence at any time in pregnancy and postnatally. The other ones are the period prevalence throughout the perinatal period. And you may say, well, even you as an audience might say, well, those other things are severe. There's blood on the floor with those and people die. Well, I'm sorry. People die from depression. And this is extremely severe. As we know from the global burden of disease, whether in a low and middle income country or in a high income country, and we are still dark blue, high income country, for how long I don't know, but whether you're in one or the other, the greatest burden of disease in women of childbearing age and burden of disease is measured by life years lost through disability or premature death. By far the greatest burden of disease is depressive illness. And you can see this is the graph from WHO of low and middle income countries data with the high income country data shown as well. But you can see it's even higher burden of disease than AIDS. In low and middle income countries. So this is a very serious condition. But if you're only into secondary care mental health and you only care about psychosis, for example, because that's exciting and dramatic, there is no other time in humans when your risk of becoming psychotic is as high as the immediate few days postpartum. No other time. And it only happens in 50% of the population. Guess who? The ones who have babies. And men have babies too, but they don't have the delivery of the placenta. And that seems to be an incredibly powerful trigger. And this probably is largely due to an increase in bipolar disorder episodes. These are also the most severe episodes we ever see of psychotic illness at any time in humans. If you're not interested in morbidity, because the morbidity figures are just so high that we can't cope and all we care about is death, and actually Jeremy Hunt is particularly exercised by mortality, safety and death. That seems to be his big issue for him, which is a bit surprising. I reckon he's onto a loser, because I don't know if he's noticed, but everybody dies. So anyway, don't anybody tell him, he can keep working on that. But if that is all that interests you, mental illness over the last 20 years is the most common cause of maternal death in women having children in the UK. And yet, we have all these specialised services for physical health care, which are effective. This is good care, but we don't have it for mental health care, even though we know so much about what we can do. And just sort of to highlight this maybe, only 25% of the women who died in the last confidential inquiry had access to NICE concordant care. And NICE was written in 2007 on this particular issue. Not only the mothers, but the children. Yes, that's right. So I'm just going to give you a very small taster of what is now a huge literature that's built up over the last 20 years, showing very, very clearly, in a nutshell, that parental, and it's not just mothers, most of the data is on mothers, but we now have data emerging on the impact of fathers as well, and that is a powerful one. But mothers' mental state on long-term outcomes in the children. And I'll show you some of the published data. This is just from 2 studies, both UK studies, both high-quality studies, one very large one and one very robust, in-depth one. So I'm giving you a little bit of a contrast. And what you can see here, this is the ALSPAC study, so children of the 90s in Avon, followed up prospectively, longitudinally. And what you can see is the strengths and difficulties questionnaire score, and that, for those of you who are not aware of it, is a very good measure of emotional and behavioural difficulties in children. And what you can see are 4 groups of women in that study. Those who had high anxiety, let's start with the bottom one. So the bottom line, low anxiety in pregnancy and low anxiety postnatally. And that's low means 95% of women. So they're defining high anxiety as the top 5% most anxious women. So this is the severe group. So low, you get an SDQ score that's essentially the same as you might expect in the general population. High anxiety in pregnancy, low postnatally is the little dotted line, a raised SDQ score, and you can see along the bottom there, these measurements are going on until 13 years of age. This study is just about to publish 25-year-old data, 25 years old, showing exactly the same effects continuing. Low anxiety in pregnancy but high postnatally, you get a similar effect, and high anxiety at both time periods, an even greater impact on the children. And that impact does drop off a little bit with age, but it stays there and the differential stays there, and as I say, we're seeing these effects continuing until the children are 25. This is not all children. This is increase in risk, really important. And it's very difficult, very unpleasant, and there will be people in the audience going, oh my God, what have I done to my children? Because that was me. Inevitably, because these are very common conditions. The important thing to remember when we're talking to individuals, when I'm talking to you, is that all of us and all of our children are born with a list of pluses and minuses. It's inevitable. As parents, we want our children to have nothing but advantages and no disadvantages, but it isn't possible. And all we do is do our very best to give them as many advantages and as few disadvantages. The other important thing to remember is that this is potentially reversible. Okay, so later relationship issues, for example, can reverse these effects in individuals, but our population at the moment isn't getting the sort of attention to this that is reversing these effects. This is an example of one other study. This is another longitudinal, prospective, very robustly done interview study from fetal life right the way through, and this is data when the children who were first studied when they were fetuses are 16 years old, and this particular element of the data looks at the children who were depressed in this study at age 16. Every single one of them had a mum who was depressed. And the strongest association was depression in the pregnancy. And that actually surprised even the researchers who weren't expecting to find this. This was originally designed as a study of postnatal depressive illness because it seemed pretty obvious that that could have an impact through behavior, through environment. And actually this has now been replicated multiple times. We know that mental state in the pregnancy, including that of the father, interestingly, but not as strong an effect, mental state in the pregnancy, independent of all the other factors we know of in relation to child mental health, has a predictive, very strong predictive power. Okay, so we had this evidence, this scientific evidence of which I've given you just a very small taster that was extraordinarily consistent, both in relation to adult mental health and children's mental health, and the subsequent adult mental health of the children, with the strongest predictors we've ever found of adult mental health coming from early childhood. But we still weren't able to persuade people that this was important, particularly politicians. So we got some money from Comic Relief to commission an economic report from the London School of Economics. And they took data from the best studies and found that the cost, not if we do nothing, but if we leave services as they are, was £8.1 billion, whereas the cost of doing everything right across the pathway that NICE says we ought to be doing was 337 million. Absolutely bonkers situation. If I would suggest to you, let's implement a fantastic strategy where you spend £8.1 billion to deliver a bad service with poor outcomes, and we'll all be dissatisfied with it. Would you like to implement that? Is that a good idea? Should we do it now? Any voters for that? Well, that's what we are doing. Even though we have this scientific evidence that tells us what we could do better. It's mad. It's completely mad. If this was cardiology, the NHS would be shut down overnight as a non-functioning organisation. But we get away with it because it's mental health. I don't know why I'm talking to you, because you're persuaded anyway. But anyway, hopefully there are some people out there who are a bit timid about mental health and early mental health being important. This is the state of play. I'm just going to stop in just a second. This is the state of play of specialist care for perinatal mental health in the UK at the moment. Red means women do not even have access to somebody who knows what they're talking about in terms of specialist care. Again, if this was maternity specialist care, physical, it would be unacceptable. And we know the outcomes are bad. About 50% of women with postnatal depression aren't recognised by anybody, even in primary care. 50% of those don't get treatment, and 50% of those don't get adequate treatment, according to NICE. So we're left with 10% of people with depression postnatally getting adequate treatment from an NHS that's meant to be based on need. Can we not afford this? Is this so expensive that we can't possibly do it? Well, we spend £2,800 per woman on physical health care in maternity. To do everything that NICE says in specialist perinatal mental health care will cost us £67 per woman. Do not tell me there is no money. There is plenty of money, it's just spent in the wrong place. And frankly, that applies across the whole of mental health care. We spend £482 million on maternity negligence costs to provide the whole pathway of care across primary and universal services in mental health in this area would cost us £337 million. And if we leave it as it is, £8.1 billion. And policy is there, in agreement, tons of it. I'm going to stop there. If anybody is interested in looking more into what the policy says we should all be doing now and in the next few years, I've got some few more slides which will be circulated. Thank you very much.
We've had 3 very passionate presentations, and now over to you. Do you have any questions? Anyone?
I hope so.
I hope so. Thank you. We have a lady at the back standing. I think there's mics coming down. There we go, next to you, on your left.
Hello, I had a question to Professor Finlay. We had 2 presentations in the morning. One was using digital medium for using CBT services, and the other one was for counseling in the morning. And I did look at your slide on listening with the Chinese symbol. So I would like to know your view of how that would relate to the digital medium for counseling and CBT.
Okay, well, I'm sorry, I wasn't here in the morning. I was lecturing at the College of Physicians, and then I was trying to sort out liberty protection safeguards, the new legislation that's coming. So I can't really comment on what you saw in the morning. And I'm not in a position really to comment on the effectiveness of otherwise, because I haven't seen the evaluations of different digital interventions as CBT. What I am aware of, though, in the digital world is the problem of fraud in the financial sectors and the difficulty for banks and building societies, now that so much is online and digital, of not knowing whether the person has capacity or not for whatever decision they're taking, let alone sometimes whether it really is the person or whether they're being coerced. And I think that is a major problem. There are some systems in banking that say that they can detect who the person is and that they can pick up if they're being coerced, but I haven't seen any evaluation to prove that they really can. This seems to be like the computer world's best wish, really, hoping that they can, and everything go over to digital. And so I'm beginning to develop a kind of inherent scepticism about abandoning everything to digital, because the times that vulnerable people are picked up in the community out there, and I'm going back to your comments about the local authority in the community, it is by face-to-face. And it is about empowering people, bank clerks, building society clerks, to think, this seems a bit odd, and ask a few more questions, and know their management will back them up. And they are picking up vast quantities of financial fraud. Equity release scheme, people who are sitting there, the clerks filling in the forms with people on equity release and thinking, this doesn't seem right, making sure they interview the person on their own and discovering that they were being very powerfully, not subtly, coerced into doing whatever they're doing. I'm afraid that not all families are loving families.
Thank you. The lady in the check, and I've got you.
Hi, I'm Wendy De Silva. I'm an architect, mental health lead at the IBI group. I'm just struck by how bonkers the funding system is. And my question to all of you on the panel is, what do you think we need to do to make people take action? I mean, I have a personal theory, which is that mental health isn't funded because of stigma. And I think people will not own up to, and it does feel like you've got to own up to, rather than just say that you have a mental health problem, or that people you're working with have mental health problems, or families have. And I think that is a huge hurdle to people actually saying this is a huge issue and we need to fund it. I think one of the other issues is that we get people on the medical world being very, very knights in white armour coming and solving the problem. And I think things like very expensive proton beam therapy, good, and it does affect a small number of people, seems to be able to get funding far, far more easily than mental health. So I'd like your comments on the funding issues, please.
Okay.
Yeah, happy to. I mean, my initial comment on that is this isn't stigma, this is discrimination. And I think we ought to call it what it is. And I think we all need to stand up and start shouting. I think the mental health community or mental illness community, and we ought to frankly merge and stop bothering with what terms we use or euphemisms and getting worked up about that. We need to get worked up about the rest of the world who's discriminating against this. And we need to be less timid. I think we've been almost apologetic. And when I look back over my time as a psychiatrist, there have been times when it's crept into my mind that mental health is a bit of a high-income country luxury. And we need to get rid of every shred of that idea because it's complete nonsense. As you saw from the burden of disease study, this is an essential part of both health, social care, but also the well-being of our nation. And I can sort of understand that our government is preoccupied by money and everything is governed by money, but actually fundamentally governments should be there to look after the population. And if the population is utterly miserable and suffering from appalling health problems that are preventable and nobody's doing anything about it, that's not government. That's complete failure of leadership. So let's shout and let's get it. There's no excuse.
Can I make a... Oh, you go on, you make a comment.
So I think there's a few things here. One is we do need to keep working at making it okay to talk about mental health, to your employer, to your family generally. And, I think there has been some movement on that, but I think there's more work to do. On the funding specifically, I think mental health faces a double challenge, because I think it does place that kind of Cinderella service challenge in terms of versus physical health, and when a health system is asked to make savings, the tendency for more of it to fall upon mental health, whether by design or by accident almost, because the focus ends up being on the acute. But I think actually also there is this issue about, which applies right across the health system, as we spend all our time tackling the symptoms and not getting underneath the causes. And the prevention and early intervention applies to other long-term conditions, but I think you've got this doubling up of an issue around mental health. And I think one of the ways, so there's a challenge right across the piece there, and I don't think sustainability and transformation partnerships will work unless the community, primary and social infrastructure is there to support whatever changes you want to make at that kind of acute or heavy service end. And I think with mental health, I think because everything in this world seems to require a business case, there is actually a business case for this, not only in terms of the kind of things you said about what we'll spend if we don't do it, but if you think about what I was saying about, if you look at adults with complex needs who call on all different parts of the public sector, and there are costs to the ambulance service, the housing authority, the criminal justice system, and so on, addressing the mental health challenges of some of those people would have very positive impact, not just on health service costs, but actually on a whole series of different bits of pie in the pie chart.
Okay, I'm going to be unashamedly putting out an advert for Wales, so there's a health warning. I think that it isn't possible, and probably our problem has been viewing the government to fix it, or that money will fix it. Resources are actually people, and people need salaries, and so the resources that you're looking to are the people to look after this, and that has to be in communities. And in mental health, it has to be linked to prevention. Wales is, and it's been signed off by our health minister, is on target to become the first compassionate country in the world. We want to change the whole way that the community behaves towards people in it who are vulnerable. I was on the select committee looking at the built environment and felt like a cracked record, banging on about green spaces, places for people to encounter, meet each other, the old-fashioned concept of the village street and the shop and the post office, and integrated areas where people can walk safely, and so on. And it's not a popular message with town planners. But they all sign up to it in theory, but then somebody comes along with some great design, and of course we all know that it gets signed off, but when it gets built it actually looks different to the plans, and the green spaces have shrunk and the safe areas to walk have got smaller. But no, as far as I know, no local authorities yet had the courage to insist that it gets pulled down, and that they build something according to the plans, that they don't stick an extra few floors on, which mean that you get less daylight lower down, and so on. So I think it is actually out there in the community, and medicine is only a tiny part of it. I heard your clarion call to close down hospitals. I just wonder where you would like to be taken when you have severe burns. You've been in a road accident and have a fractured vertebra, or minor, you've got a fractured femur. Well, that's pretty minor compared to if you've broken your neck. And actually, I think it's terribly easy to look at things from our own perspective. But we do have to think, if our kid comes off their bike with a head injury, do we really want there to be no paediatric intensive care in the hospital that they get taken to because we put all the money into dementia services or something else? So I think there are big societal discussions that need to be had. And there has been this message somehow that we can sit there like little birds in a nest with our mouths open, and we just can't do it anymore. And so the community has to turn it around and begin to take control. And as part of that, through the Bevan Commission, we're working with the concepts of prudent healthcare, and the questions to society about how will you contribute to the health of your own nation our nation is Wales. Sorry to be parochial and devolved. There you are.
But even in Wales, you have too many acute beds. My mother, before she died 2 years ago, was admitted 3 times to hospital, having fallen over in her home. There was nothing wrong with her apart from that she'd fallen over. On each occasion, she spent more than 10 days in hospital. On 2 of those occasions, I had to sign her out of hospital and take time off work to look after her, because I could not even get private care for her that I would pay for. There was no NHS system to care for her. She required an infection on one of those occasions in hospital. On her ward, she was surrounded by elderly people saying, "Get me out of hospital." The examples you give are, in a way, either not in touch or disingenuous.
No,
And I'm sorry to be controversial
Okay.
here, but I worked through the closure of large asylums and psychiatric hospitals. My first job as an SHO, the only equipment I was issued was a bicycle for internal use only, and I looked after 120 long-stay patients. Thank God we closed the hospitals and we kicked the consultants out of their offices in the hospitals into the community. We have not done that in acute healthcare, and the consultants do not want to work in the community. They want to work in hospitals. It is about time we change that, and then we can start talking about whether the NHS needs to be privatised or the system is broken, when we stop wasting money on care for people who do not want the care and who are being harmed by it.
No, I'm not arguing that we should be keeping people in hospitals, but if you're going to have people out there in the community, you have to have services out there in the community, and you have to have people working in them, and you have to therefore have services that people want to work in because they feel proud of working in them, they feel supported, and they feel valued. And at the moment, that isn't necessarily happening in the community. So you've got to get the whole flow through the system to make it work. But I do worry about simply talking about closing things down without looking at where things will go and to deal with other issues. And now some probably got a bit too low on mental health beds, perhaps, intensive care beds for children and teenagers and so on. I don't know, you can argue about that amongst yourselves, but it seems rather sad to have to go to court to get somebody placed.
It's a
so
difficult...
It seems
there
very
are-
tragic that they can't
there are
get care in the
tensions.
community when they really need it, and they then end up in
Right,
hospital.
but you get care in the community by services being there and by that being valued and having an infrastructure, and that is down to the whole of society. And I'm just not sure that you can put all the blame at senior people in medicine for that. I think there's a much broader debate to be had.
It's a big debate, and it's one that we can argue for a long while. And we talk quite a lot about joint working. I think I've heard that throughout my career as a psychologist. And I've heard quite a lot about collaborative working, and I've heard quite a lot about community connecting or community working with the community and bringing the community together. But it needs some work. It can't just happen in vacuum. And the most vulnerable in our society, and those that are excluded from many things or are like mothers or like elderly or people with learning disabilities, sometimes all they need is some solutions that are from the heart. And we start to really practice what we preach and start to actually think, how can we provide 1 hour a week for each individual, rather than saying you don't meet those thresholds, and that hour can come from the voluntary sector, can come from anywhere, but that 1 hour might be that needed connection that person might need, that might keep them out of hospital, that might pick up that there's issues happening. But I'm not going to carry on because there was someone with this hand up at the middle there, and the gentleman in the middle, and I'd like to hear your question. Thank you.
Hi, my name's Ben. I'm from the NSPCC. I just had a question for Alan. Thank you for such a powerful presentation. I was just interested in how you went about calculating the costs of not acting. because the NSPCC is kind of keen on doing a similar study on the cost of not acting early on, for children who've experienced abuse.
Well, the NSPCC is a member of the Alliance, so we've had a lot
Not
of
me
help
personally, but
from the NSPCC. But if you're interested, go to the report from the London School of Economics, and you'll find that on our website, the Maternal Mental Health Alliance website. And there's a detailed report giving all the details of how the calculations are arrived at. And it's a gross underestimate because they only took evidence based on the best data available. And there were some areas of mental health where there just wasn't good enough data. So it's based on data relating to antenatal anxiety, postnatal depression, and postpartum psychosis, only those three conditions. And it only looked at the outcomes for the first 10 years of a child's life in each annual cohort of women giving birth. So since then, we've got better data on a lot of other conditions and data into the 20s of those offspring showing those effects. So it's a gross underestimate, but do have a look at the data.
But actually the first 1,000 days is really powerful. You don't even need to go as far as 10 years. The first 1,000 days.
Well, they're a powerful predictor of the next 10 years. That's why the first 1,001 days.
That's very, very powerful data.
Absolutely.
That's
But it's the
absolutely
same
critical time.
I'll take one last question. Is there a question? There is a question up there.
Hi, I'm Olivia and I work at the British Medical Association, and this is for a question for Alan as well. So the money that David Cameron promised, I think a few years ago, the 365 million. So I saw on the map, the provision of perinatal mental health services, that's from 2015. Mm-hmm. Is that money making a difference to frontline services now in 2017, and what difference is it making?
Yes, one wave of that money has now been issued, and we have 20 new community services serving nearly 90 CCGs. And we would expect the map to go green in those areas, and this is England only at the moment, the map to go green in those areas during the course of the next 12 months. Then wave 2 is about to be announced, so we would expect to see another tranche of CCGs. And then in 2019, the ongoing money, so that was a 5-year figure, but it comes with a permanent additional fund to go to CCGs for this, but it cannot be ring-fenced. There is no mechanism for ring-fencing it after 2019. So we are going to be working very hard and campaigning very hard to make sure CCGs spend it on what it's meant to be spent on. In Wales, they have done much better than in England.
Wow.
What they did, of course...
I believe you think we've done something right.
They don't have the commissioner-provider split. The money arrived in Wales, so the equivalent sum per birth arrived in Wales, and they immediately set to spending it on people on the ground, as you were saying, who need salaries to do the work, and every part of Wales has now gone from red to orange. But unfortunately, they don't have enough money to go green, which is nice concordant care. So we would expect Wales to need to make a decision at some point as to whether they want to commit just a tiny bit extra to make it all go green. And that will change the lives of women and children in Wales for centuries.
Thank
So
you.
well done, Wales.
One of the things is too about you do have to take a long-term view and put training posts in so that you're growing the next group of staff and you're growing the capacity in the workforce. And that means making it attractive to the workforce. Again, psychiatry doesn't have the largest number of medical school graduates queuing up at the door. It has a lower number of applicants per place than many other disciplines. So it's not the lowest, but and it's going up in the States actually quite well. You're doing quite well at attracting them, but you're not there yet.
Well, it's actually perinatal psychiatry that's had more new jobs in the whole of the NHS, and we've had absolutely no problem filling them because people think this is the most wonderful job in the world, and I can tell you it is.
So I'm going to ask our panel to give us one message that they'd like you to leave with today.
I've forgotten we were going to be asked about one message. So I think my message is about that general message. We've got some really great specialists who absolutely know the heart of their very specialist bit of business and absolutely passionate about it, clearly. I'm a generalist with a social care background, and I think that we have to make sure that we are all playing our part, whatever organisation we're in and in whatever role we're in, whether we're a parent, a friend, an employer, and so on, because actually, these are all parts of the jigsaw of getting it right as a nation.
As a nation, we have to invest in parents, particularly parents of young children. That will be the greatest future investment in infrastructure, never mind HS2. It's people and the future of the population and their mental well-being, their mental functioning, their cognitive functioning and their physical health that will govern how successful this nation is. And that can only come by nurturing parents.
I think I'd go back to what Sarah said about people and the capital of people within the population. Healthcare will not solve or do the prevention that needs to be done. It will happen in schools, it will happen out there in communities, it will happen by empowering people to be connected and to stop being risk averse and thinking that you have to be signed off on this, that and the other, but actually having the courage to ask the question of the person who, for whatever reason, doesn't quite look right or comfortable or whatever, and intervening really, really early, because all the evidence is that by the time people present, you're already too late most of the time. But that ownership in the community means about the community building its own resources, insisting on green places, insisting on safe places to work, to walk. And one nice thing I heard the other day is that a community in North London has just got their library reopened as a community resource. I was astonished. And they've had lots of people go and volunteer to read to children and read to old people and so on. And actually, that's the kind of resilience that you need to begin to build back into communities, because we've become far too fragmented and far too selfish.
And my last message, I'll indulge, is for us to remember those that are seldom heard, the most vulnerable in our society, and those who have mental health issues, or those with learning disabilities, or those from BME communities or newly arrived. We need to make sure that we are reaching and really hearing with our hearts, because we have become a different society. But one thing that I'm very clear is that we need to talk to each other, the specialists, the generalists, and we need to start finding local solutions. Unless we start talking to each other and have a roadmap that really focuses on prevention and thrive in terms of having communities that thrive, having communities that care, but also reach out, I don't think we'll ever get there. So thank you very much to our panel. It's been really interesting. I think you would join me in showing our appreciation for their presentations and their time.